All right, good afternoon, everyone. I know a few folks are still joining us, but we're going to go ahead and get started. So welcome to today's conversation where we'll explore the pros and the cons of an opt-out and an opt-in organ donation system. My name is Deanna Fenton, Senior Manager of Educational Development here at the Alliance, and I have the pleasure of joining you all to kick off today's discussion. Now, today we have the honor and the privilege of being joined by our friends from the UK National Health Service team, who will share their rationale for adopting an opt-out model and highlight lessons learned since transitioning to a presumed consent system. Additionally, we'll hear from leading experts in the US who will provide their insights and opinions on both models and their potential impact. Now, before we get started, I'd like to take this opportunity to remind you all to take note of the chat feature that's located in the navigation bar at the bottom of your Zoom window. Certainly, over the course of today's discussion, we'll want to hear from you so we can address any comments or questions you may have. Now, for those of you who may have submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have them addressed over the course of today's discussion. That said, if you have any additional questions, please don't hesitate to submit them in that chat box. Now, given the nature of today's discussion, I'm pleased to share that we will be offering continuing education credits for your participation. Following the conclusion of today's program, you'll receive an email from us with detailed instructions on how to complete post-event evaluations and claim your credits. Now, as always, today's session will be recorded and made available on demand for your convenience. The direct link and PowerPoint handout will also be provided via email following the conclusion of the program. But you can always find that information on our website at organdonationalliance.org. Lastly, for anyone joining us today as a group, we'd like to ask that you complete the following poll to indicate approximately how many people have joined your group. Now, with that, I'd like to go ahead and begin today's program by welcoming our moderator, Dr. Cynthia Grease, who serves as the Medical Director of Lung Transplantation at Advent Health Orlando. Cynthia, it's always a pleasure to have you with us. And at this point, I'll leave it to you to go ahead and get us started.
Well, hi, and welcome everyone to this really exciting session today. I have the pleasure of introducing our speakers for today. If you can just advance to the next slide, thank you. So we have a great group of panelists. We have two individuals joining us from the UK, both Anthony Clarkson, who's the Director of Organ Tissue Donation and Transplantation for the NHS Blood and Transplant. And then we also have Claire Wilmont, who is the head of legislation implementation for NHS Blood and Transplant. So they're going to share their perspective about implementation of opt-out that occurred in the UK and some of the trials and tribulations of what they have gone through. And then we're going to hear a little bit more discussion from a US perspective of some of the discussions that have been happening from Tom Moen, who is the Chief Executive Officer at One Legacy in California. Also, Brad Adams, who's the President at Southwest Transplant Alliance. And finally, we will also hear a little bit more information from Shelley Hall, who's the Chief of Heart and Transplant Services at Baylor. So with that, we're going to actually kick off this discussion first with Anthony and Claire. They're going to kind of share what their experiences have been like with the UK experience. So take it away.
Thank you, Cynthia. Yeah, the UK has had about a 20-year history of debating whether we should have an opt-out or an opt-in system. And going back 20 years ago, there was a hot discussion about this and whether we should put other measures in place to increase organ donation rates, because we'd had a number of years of plateaued increase in organ donation. So a task force was put together by the UK government to look at organ donation. And at that time, it suggested that we put in place the infrastructure to support organ donation. So put the coordinators in, we created one OPO for the whole of the UK. We put in clinical leads in every intensive care unit in the UK. We put in donation committees, etc. And we put all this infrastructure in place. As a result of that task force, there was 14 recommendations. The task force also considered whether we should move to an opt-out or an opt-in system, and it suggested that we kept an opt-in system at that time, but left the door open to move to an opt-out in the future. And the reason for that was because it felt that we needed to put the infrastructure in place first to see if that made the difference. So that was in about 2008, and we spent the next 5 years after that time putting that infrastructure in place, and we saw a 50% increase in donation rate during that time. But that 50% increase was pretty much totally due to the infrastructure that we put in place. The consent rate during that time hardly budged and remained in the mid 60% range. Since then, we've continued to focus on consent, and the second strategy we had in the UK focused on consent. And at the end of that strategy, that's when the opt-out legislation came in, because again, we were seeing a very slow marginal increase in consent rates. And the governments decided that they wanted to look at opt-out again, and there was a groundswell of public opinion that we should move to an opt-out in the UK. Wales, as you know, went first with moving to an opt-out system, and then England went with an opt-out system last year, and then we've got Scotland as well, and Northern Ireland due to come. And then we have some islands around the UK that also have their own legislative system in place that are also moving to an opt-out system. So the UK as a whole will move to an opt-out system, and as the whole of the UK will be opt-out probably in about 18 months' time, we suspect. And this has been a significant change for us here in the UK. But it was primarily driven by the fact that we had seen significant increases in organ donation, but it wasn't due to the consent rate. And we wanted to use this as the last kind of tool to try and increase the numbers of organ donors in the UK. So that was what was behind it. In relation to the public opinion, in England particularly, it was driven by the media actually that got behind moving to an opt-out system. So as you're probably aware, the media have got quite powerful in the UK, and the tabloid media, and one of our famous newspapers actually supported the move to an opt-out using a case study that Claire will tell us about in a minute. So that's kind of the background history. And then moving through into implementation, we gained a lot of experience during this time, and I'll bring Claire in to tell us about that period.
Thanks, Anthony. So in England, as Anthony just mentioned, the media played quite a large part in the introduction of opt-out, and it's partly building on the fact that the task force had been completed, the infrastructure was all there, but we still hadn't seen that shift. And also there was learning from Wales, where they'd implemented opt-out legislation back in 2015, and it had been quite successful. And actually in Wales, at some points their consent rates started to hit 80%, which is up there with Spain. So obviously something was changing, and they hit statistical significance. So they got particularly behind a young boy called Max Johnson, who was in desperate need of a heart transplant when the opt-out campaign started within the Mirror newspaper. And as time moved on, he actually received a heart transplant from a young girl called Kira Ball, who tragically died in a car incident. And one of the real benefits of the opt-out legislation is in England is that it's put that focus where it should be on donors and their families, as well as the transplant patients. And in England, it's Max and Kira's law. We don't talk about opt-out legislation, we talk about Max and Kira's law. Because the huge role that they and their families played. And we spent quite a long time, as the law was progressing, working with colleagues to engage with them and seek views about what the right way was to implement the change in legislation. And whilst the legislation is fantastic and a real driver, it actually brought a lot of benefits as well within the UK. So just the fact that you've got a government that's that committed to organ donation starts to bring benefits. So we saw as a result unprecedented levels of funding for media campaigns and marketing. We'd been across the UK campaigning for probably 20, 30 years to get organ donation onto the mandatory school curriculum in the UK and in England, and never managed it, but managed that as a result of the change in opt-out legislation. It brought other benefits in terms of things like we have an organ donor register, and we, as the law was being developed, we engaged a lot with different faith groups and as part of the consultation process, and some of the responses that we got back from there changed things like our organ donor register, which now includes an option to record that you have a faith or a belief, and you want that to be taken into consideration as part of the donation process. So you want to be a donor, but you want your faith and belief to be taken into consideration. So there are those kind of benefits that aren't actually anything to do with the legislation. None of that was written into law. It's just when you've got that political will and that drive and that focus, it opens up lots of doors. And some of the other doors it opened were things like discussions with faith groups and belief groups and other community leaders that had not really engaged with organ donation before, or in some cases were not sure about organ donation, wasn't sure whether it was something that was in line with their faith or beliefs. And the change in law opened the doors to that conversation. It kind of encouraged people to really think about it. And as a result, we spent a lot of time talking to those people. And as a result, we've got incredible, really strong working collaborations with groups and people that we just never really engaged with before because it just wasn't up on their agenda. So it's been incredibly helpful for that perspective as well. There's also things like like I've just mentioned, the wider engagement as well with people like the bioethics and the parliamentarians themselves, just getting that debate in Parliament and getting the public awareness. So the legislation has gone so far, but just the fact that it progressed has developed all sorts of real benefits. It's too soon yet to say what impact the change in law might have on consent rates in England and Scotland, where they only went live in 2020 and at the height of COVID as well. So it's really difficult to judge exactly what that impact might be, but we're watching closely and we've got a large program of evaluation underway to make sure that we are keeping an eye on that.
It's worth pointing.
Oh, go ahead.
I was going to say it's worth pointing out, Claire, that in England and well, in the whole of the UK, it is a soft opt-out system that we have. So the families are always involved in that discussion around organ donation.
Yeah.
So some of the questions that were sent in during the registration process really kind of focused on how did you engage? I mean, you talked about using the media, but how do you communicate with the public and have the public have feedback? Because I think that's probably a concern in the US is, you know, how will the people in the US respond to something like this? So how do you engage them to move them forward?
Shall I make a start on that, Anthony, and then you correct me if I go wrong? So in the UK, the government, rather than NHS Ban Transplant, the government launched a consultation not on whether to introduce opt-out, because there was already very, very strong support. So over 80% of the people in the UK support organ donation. And there was the growing media campaign, and there had been a call for opt-out from patient groups and from donor families for, as Anthony said, 20, 30 years. So there was a real strong sense of opt-out was the right thing to do. But so the government launched a consultation not on whether to introduce opt-out, but on how to introduce opt-out, because there are lots of different ways that can be done. And in general, in the UK, if the government in England launches a consultation about legislation, they would see it as a really good event if they got 200 responses. Say they got 17,000 responses, which was absolutely unprecedented, and I think was quite a shock to them and across the whole of Whitehall. But the overwhelming majority were very, very supportive and just wanting to get in on that discussion and in on that debate. So, and that was partly driven because of the Mirror campaign had done so much, but also a lot of the responses weren't just from the general public, but they were from people within organ donation or transplantation themselves. So the donor families had a very large voice, and our specialist nurses and our clinical leads for organ donation and the transplant teams. And so lots of people in intensive care all use that as an opportunity to say how the law should be introduced. So there was a huge level of engagement as the law actually started. And then as that progressed, throughout the legislation process, we kept that discussion going. We kept engaging with the people that had reached out to us, and also we did a big marketing and awareness campaign for the general public to let people know that it was coming. We used all of our different avenues with representative groups and different community leaders to make sure that the messages were getting out there into the different communities in ways that they could understand. So we did peer education, so that, you know, faith leaders or community leaders could go out into their communities. We put stuff on our website. We went, you know, used any available opportunity we possibly could, and me and my team never turned down a single opportunity to go and speak at any meeting, whether that was, you know, some big national conference of, you know, oh, sorry, lights have gone off. Whether that was a big national event or whether that was just, you know, a small town hall type discussion, we went and spoke to everybody that would be willing to speak to us. And I'll pause there because obviously the lights are going out and it's time for me to go home.
Claire,
You look beautiful.
Just a quick question. What's the mechanism that you give people to opt out, and what kind of percent or opt out are you seeing with your systems?
The mechanism to opt out is exactly the same as the mechanism to opt in. So we have an organ donor register. It's national, and it takes, you know, 3 or 4 minutes to complete. You go in and you either tick yes, I want to donate, or no, I don't want to donate, and then you know, complete your name and details. It's slightly different because, like I said, if you're opting in, then there's the option about, you know, what's your faith and beliefs, and how do you, obviously that's not relevant if you're opting out, but it takes exactly the same period of time. And in the UK, there's no big register with every single person's name, and if you haven't registered a decision, we consider you as a donor, so your name goes on as a donor. It's reliant on people actively going in and either opting in or opting out. That's not the case in some other countries. So for example, the Netherlands, they do list every single person in the country, and if they haven't recorded a decision, they get their consent deemed for them. And the legislation in the UK, whilst there is the organ donor register, and that's what we encourage everybody to do, actually a verbal decision that you've shared with your family or your friends, or something that you've put on social media or whatever, is just as strong and as valid as a decision on the organ donor register. So it doesn't dictate that you have to make that decision on the organ donor register. You can just, you know, have a conversation with your partner, your spouse, your parents, or whoever, your best friend, your neighbour down the road. We don't mind, provided you have that conversation.
So if your public has the opportunity to just say yes or no, which would be so much simpler than using these terms of opt-in and opt-out, because I think they confuse people. You basically, do you want to be an organ donor, yes or no? How is that conversation different when you were an opt-in versus an opt-out, if it's just a yes or no?
Yeah, so I think that the change in legislation hasn't delivered a huge change in the way that we actually approach families. We will always approach families. We will always check the organ donor register. But I think the impact of the change in legislation is that it shifts the presumption. It allows you to go in with a, right, we can't see any change, and we can't see any registration here. They've not recorded any decision, so we can, you know, we can consider them as being happy to donate. Is that what you know about your loved one? Is that, you know, have you got anything to make you think that they didn't want to donate? If not, we need to talk to you about how donation might be able to happen. So it gives specialist nurses that ability to have a slightly different conversation. It shifts the power onto the positive, or onto the presumption, which better reflects, actually, like I said, that 80% of the population support organ donation, rather than the assumption of we don't know what they wanted, there wasn't a decision, so actually you have to make the decision for them, which puts that onus on the family. Anthony, is that fair? Is there anything else you want to add?
I think it is. I think the only thing to add, Shelley, is that with the public at large, we ask them to make a decision. So to join the register and make the decision, yes or no. So actually, we try to avoid the opt-in, opt-out terminology, because it's very confusing. Because whilst we have an opt-in register, we're almost asking the public to opt in when they know it's an opt-out system. So it actually gets quite confusing. So we just say to them, make a decision and record your decision and tell your loved ones. So that's how we would do our marketing.
So Howard Nathan asked the question about how the critical care doctors have responded. And I wonder if, just to kind of take that one step forward, have there been studies of how end-of-life conversations have changed with the implementation? Or do we know anything more about how the doctors have responded?
So we did some evaluation in Wales around that, and as England progressed through their legislation, we did a lot of work to engage with the intensive care doctors to gauge their views about, like, what are your concerns? Do you have any concerns? If so, tell us what they are, and we need to think through how we can address them. And if not, how do you feel about it? Are you excited? Are you nervous? What do you need from us to help you through? Because this is coming. So, and we used that engagement activity as the law was still being drafted to help inform, and we sort of fed that into the government to say, this is what the intensive care community are telling us. You need to consider that as you consider, where opt-out doesn't apply, for example. So it doesn't apply to children, or it doesn't apply to people who lack capacity, and so on. So the intensive care community was actually, I think it's fair to say, when Wales first got going, slightly more nervous, because it was the first country in the UK, and the NHS is quite a different beast to Spain or other countries that had introduced it. But it was we learned from experience in Wales and made sure that we took the intensive care community along that journey with us and just asked for their views at every single stage. And I think that helped provide that reassurance and get the feeling that they were part of the policy making process as well, and that their views genuinely were being held, taken into account.
And just to add to that, there was also, particularly when we were introducing this in Wales, there's a lot of concern as well from the physicians and the surgeons that undertake the organ recovery. Because in the UK, they carry the liability for the consent. So if the consent wasn't in place and they removed the organs, it's them that would be liable. So they were concerned about, is this valid consent? Are we going to get challenged that we removed the organ and then find out later that there wasn't appropriate consent in place? So actually, Wales going first and being a much smaller country than England, it really did help to build the confidence that we weren't going to come across some of these issues.
One of the things with the US is we love to be contrary, and we love to file lawsuits. Was there anything like that happened in your country, either patient groups or lawyer groups or things like that?
No.
You guys are so nice.
I mean,
very polite.
To be fair, we spent a lot of time considering how to implement the change in legislation to ensure that we did it in a way that was going to be safe and proportionate, and so I think that probably helped. So we spent years planning and then executing the implementation of the change. So.
And also we spend a lot of time. I really can't stress for anybody that's looking to potentially introduce opt-out legislation, I cannot stress the amount of time that you need to put into it enough in going out and reaching out into different communities, into different faiths, and having that conversation and saying, are you concerned about this? If so, why? And let us talk to you. And in having those conversations, we were never, you must support organ donation. We were always very, very neutral and just saying, this is the way that our processes work. This is the way that opt-out would work. This is what the system would be. Are you comfortable with that or not? So we were very, very, focused on the decision is yours. We want you to make a decision. I don't mind whether you opt in or you opt out, but I want you to do it from a basis of knowledge. And a lot of that work was just myth-busting around organ donation in general. You'll switch off my organs, you'll switch off my machine just so that you can have my organs. The usual myth-busting work that we all deal with every day just comes really up to the fore as a result of opt-out legislation. But like I was saying earlier on, it forces some of those conversations and makes people engage because the law is changing. And so it really opened up those doors and was really, really, really good and collaborative. It started off very difficult, some of those conversations, but as we moved on, people felt reassured that we were being honest and we were, putting up seeing through all the actions that we said we would.
And Claire, as a soft opt-out system, when someone does register their decision that they say, no, I do not want to be a donor, you're not working with those families, correct?
As a general rule, if we check on the organ donor register and we see that there's a no, the family will still be approached, but we can say, because that's part of just making organ donation a standard part of end of life care. So we'll go to the family and say, right, we check the organ donor register, we can see your loved one opted out. So organ donation isn't something that we're going to be talking about now. And then we sort of pause for a couple of beats, just in case they know anything that's different, because even if there's an opt-out opt-out registration or indeed an opt-in registration with us, the family might know something that's more recent. So somebody might have opted in 15 years ago, changed their mind 2 years ago, but never got around to changing their organ donor registration, or vice versa. So we will still approach the family, but if it's an opt-out, we just say, we can see they've opted out. So that isn't something that we'll be considering at this point in time.
I just think that's an important point of clarification or clarity for everyone, that a soft opt-out system specifically is that you're actually still looking to the family for those who haven't registered a decision. And for those who are even registered a yes decision, that you're still visiting with the family about that. It's just that it's offering the opportunity for someone to register a no as to organ donation is really, so whether truly opt out as a soft opt out may be a little less dramatic impact or effect to that point.
So there's a lot of questions that we've received online and through the chat about the changes in numbers of how this has affected donation rates, but also how many people have decided to opt out. I think Tom has some slides on how donation rates have changed. So I don't know if you want to share some of those, but before we talk through that, do you know the numbers of opting out there, Anthony?
Yeah, so it's actually it's about 5% the population that's opted out, or just lower than 5%. So now we don't know. We actually thought it was going to be a bit higher than that when we first were looking to implement the opt-out system. So you could debate whether that is because not enough people know about the opportunity to opt out, or whether it's actually people are not that concerned about opting out and actually support the opt-out legislation. So that's that's the data at the moment as it's showing, and it's pretty consistent. It's sort of plateaued at about that level. And that's the same in Wales as well, as well as in England.
Well, I'd be happy to speak to some of the international data behind some of these to do as a comparison. Obviously, we know here in the US, we are an opt-in system, but we are a unique opt-in system because we have a tremendous legal reliance upon donor registries, in which, depending on how you count it, as many as half of Americans are registered donors, and we don't ask the family permission. We follow through on the donor registration. So that is unique in the US as compared to really any other country in the world. So looking at the countries in the world, this is looking at 2020 data, 3 different ways of measuring it. There is no ideal single measurement of donation rates in countries. The traditional one is donors per million population. It's largely used throughout most of the world. And this data is all provided by the IRODA, the Spanish group that has tracked organ donation transplantation rates for decades here, in the most recent 2020 data. And you can see here in donors per million population, the United States at 38 led the world in 2020, Spain right behind at 37.9. And you'll see across most of these, all 3 graphs, the US and Spain are the world's leaders in this. And the rest of the top 10, the group of countries are measurably lower. On these bars, you'll also notice that the green bar represents an opt-in, and blue bars represent opt-out. And if you look at donors per million population, it is clearly the majority of the top 10 are opt-out countries. And again, these are soft opt-out. Every one of these countries, there was a sort of landmark study a decade ago by Johns Hopkins team, and Brian Boyarsky interviewed 17 different countries' donation leaders, and who had opt out versus opt in and verified their methodologies, and it's very much as described in the UK model here. If you look at donors per 10,000 deaths, and this reflects the fact that countries' death rates vary dramatically, regional death rates vary dramatically. In the parts of the US, there are places like the state of Utah where the death rate is 5.8, and the death rate in West Virginia is 12. The population is not a really good measure of donation, and you see the same around the world because death rates vary as the aging of populations. So looking at donor 10,000 deaths, you're a good deal more accurate to the effectiveness of the donation system. And here it's interesting, you're beginning to see countries, more opt-in countries showing up. The US again leading at 42.7, Spain at 40.3, and Slovenia sneaking up there at 28.5. I think we had a minimum of a population of 1 million or 2 million, just keeping Iceland out of there. Sorry, Iceland, but 300,000 people should not change our thinking too much. But Australia climbing substantially over the last decade or so to 27.3, Canada 24, and France, Belgium, Austria, Norway, Finland. Again, so donors per 10,000 deaths. And you notice under here, I have the UK data, and the UK data that is published by Iridot and donors per million, not quite making some of the overalls for the 2020 data. 2020, of course, skewed by COVID, so it's really not the best. And it is worth seeing where they are changing between 2017 and 19, probably as a better view. And then, so again, in 10,000 deaths. Of course, the end goal of donation is transplantation. And what is the transplantation rates per part of the population of the country? And the population of the living is a more appropriate denominator there. And in the US, it's 103, this is deceased donor transplants, not including living donation, 103. Spain at 88.7. And you see Austria, the Czech Republic, and Finland, four opt-out countries, followed by Norway and opt-in, Portugal, Belgium, opt-out, and Sweden and Denmark as opt-ins. It is pretty clear here that while donation rates are one thing, it's the number of transplants that result is the ultimate measure we're seeking. And you can make a compelling argument that at least one version of opt-in seems to be holding its own pretty well, and the others are a mixed bag. And I would just sort of my own sort of personal opinion here. This has a lot more to do with the culture of the countries, the long-standing history and political makeup of the countries, than it does to do with the laws per se. One of the things we know about the U.S., and I think Shelley made the point very earlier, that we tend to have maybe a skeptical attitude toward the role of government, and in a country that doesn't, where people do not want the government taking their guns, they don't want the government telling them they should be vaccinated. The notion of the government taking their organs may be a more difficult sell here than it would be in countries where there is a greater trust and reliance in government and political leadership. So the culture and the background has a whole lot more to do with this than the underlying law. I think the one thing that I will finish with is one of the things we learned in the work that Alex Glazier and I did in this piece in JAMA was the thing that does seem to work for the U.S. most significantly is that we have the legally binding registration. If we don't ask family permission, we describe how it's going to go, and in most cases, 99% of cases do go forward to actual donation. In addition, we get a second chance if the individual didn't register. And we don't make it easy to say to record your non-registration decision. If they didn't, then we get to ask the family, and that's probably the unique element of the U.S. and the rest of the world. And my view is probably why we're sitting up here at the highest number of deceased donor transplant rates. And with that, I'll drop the slides, but I can bring them back later if somebody cares.
Yeah, and to pick up on that from where Tom is leading off, while we do perform as one of the top performing donation system in the world, it still begs the question, and Dr. Hall and I have this conversation all the time about how do we do better? How is that even though we're doing the best, how is it that we can still do better? And if you'll share the slide that I was able to put together, just a couple of pieces of information that we look to when we have that conversation. First off, we know from the 2019 National Survey of Organ Donation Attitudes and Practices that was conducted by Gallup and sponsored by HHS, we know that over 90% of Americans support organ donation. You can see that in the top bar. The second bar, though, how many people have actually signed up as an organ donor? At the time of the 2019 survey, nationally, it was about 50%. I know we here in Texas have about 55, 56% of our adult population in our registry. So why the delta, and how can we make up that difference? Well, the delta partly explained also by some of the other responses in the survey, that individuals still believe that if I'm registered as a donor, my doctor may not do all possible to save my own life, or that I can actually recover from a brain death diagnosis. You can see in those percent totals there, 32 and 42%, that's making up about that delta between who is registered and decided I'm willing to register that decision versus I support it, I just want to wait and let my family make that decision for me. So then as we look at, okay, so would opt-out possibly move the needle for us with over 90% supporting donation? We look further into that survey to see that those that support presumed consent are over 56% of the population. Again, those that are consistent with those that are willing to go ahead and register. But the most important part of that survey to us is that when asked whether they would opt out of a presumed consent system, over 34% of Americans actually responded that they would actively opt out. And as we discussed under the soft opt-out system in the UK, that is something that if, as we have seen it as proposed as legislation here in Texas, we wouldn't have a chance to visit with that individual. That would be the binding decision instead of the decision to actively opt into our system. As Tom mentioned, because our system itself is set up under gift law, it is a binding legal decision on behalf of the individual that does register their decision to be a donor. And when we realize 98, 99% of those individuals who go on to donation, but we still have a chance to ask the family for those who didn't ask the question. Where there was a newly revised book by Thaler and Sunstein, both Nobel Prize winning professors, a book called Nudge, who dedicate an entire chapter to this topic. And they talk about really what you want to do is set up a question that individuals themselves will lead them to the answer that they want to give. We have over 90% that support donation. We want to set up a question for them that leads them to make the decision that they want to make in the easiest way possible. And that question that we've structured is, do you want to join the registry to be a donor? Not whether or not you want to be a donor. We don't want to ask people if they do or don't want to be a donor. We just want to ask if you want to join the registry. That's who then says, of our, again, 55% of our population today actively registering to be a donor. But it gives us that opportunity to visit with the family when they say no to the registry, they're not saying no to donation. We've proposed that question to them. It's a prompted choice system as they reference in their study. So something that we think that if we were to switch, again, certainly performing as the best in the world, would switching to opt-out actually move the needle for us to being even better? We're concerned that it wouldn't be. The numbers that we run on that, when we look at 34% that would actively opt out, we're already starting at a 66% potential, because 34% we can't even approach. If under our current opt-in system, with those that register and families that say yes, we see about a 75% overall authorization. So that delta of about 10% in Texas alone would result in 2021, would have resulted in 420 fewer organs available for transplant. That's the concern that when we address this topic, that's the concern that we feel like we're facing. Dr. Hall always has great comments on this as well. That's who we get to have the conversation with down in Austin each session. And again, all of us aligned behind the same policy of trying to increase donation, trying to promote donation in our country, and figure out how to get to that 90% as best we can, just thinking that there may be different ways to go about that.
Yeah, so I would say a couple things. I mean, obviously, I talk a lot about how I feel that our country could benefit from opt-out. I think number one is throwing away both of the names. As I've mentioned earlier, the names confuse people and create these sort of dystopian visions of, government officials coming in the middle of the night and stealing your organs. And that's where, that's the fear represented by statistics. About a third would be like, oh no, I'm not going to go and consider that. I'm going to definitely opt out of somebody trying to take my independence. As mentioned, our country has been pretty stubborn on so many what seemingly are medically rational things because of fear and misinformation. And so, I mean, I think the some of the things mentioned about how you rolled it out in the UK are the key. All right, the infrastructure first is vital. You have to have it. And I think that's something that this country, our country has. We have a really good organ donation infrastructure now. We have, you know, dedicated professionals. Most hospitals have people involved. The OPOs. I mean, we're very, very active, and so that part is there. So then it's like, okay, we're doing that part. Where can we go? And you know, there's another statistic or number, and I always call statistics funny math, called the eligible donor designation rate. And that is, you know, at the time that they were a donor, how many of them were registered. And I could find information about the US, but I couldn't find something nice and concise for all the countries. And in the US, it ranges from the teens to the 80s, depending upon the state. And it's not politically necessarily affiliated either, you know, that the lows are one party and the highs are the other party. It's a real scattergram. So, you know, this isn't, although politics are often pulled into this, it shouldn't be. It's not a political thing. And so we need the education piece. You know, say this passed. And in the US, it'd be state by state right now that something like this would pass. So just as you had country to country in the UK, it would be going state by state in the US. And you know, there's this big joke, if Texas could pass it, anybody could. I probably that's correct. But so the first is the infrastructure, which I think we have. The second is the education piece, the myth busting, as you mentioned. That is going to be crucial to educating. And then the softness of it. I think if we were to suddenly do some draconian, you know, you are all organ donors and you can't say, that would be a disastrous policy change in this country. It has to be soft. You know, if we got rid of the verbiage and it was simply, I mean, I love the terminology of, would you like to register for would you like to sign up for the donor registry? That should be the question. And not, do you want to be an organ donor? Because the fear is then you're asking me now, do you want my organs? After I get my license, am I going to donate an organ? And so all of those misperceptions that we would have to work on in preparation for a type of opt-out system. Obviously, I think you always have to have the family ability to refuse or consent at the time of the death. I think that is only feasible in this country. The faith preferences are huge in this country. And then a big component that you mentioned in the UK is the media. Okay, media has not been particularly helpful in our country, and to get them enrolled and being beneficial. I mean, I can see just as many commercials trying to say the government is stealing your organs as I would, you know, that say you can help Billy, right? And so I think the media campaigns, aligning them with the message is going to be very important in our country, or it would be a disaster as well. So those are some of my kind of initial thoughts to the way UK does it, the way the US could possibly do it, because the reality part of our success in the US with our numbers of transplants is because we have more transplant centers than any other country per population density. I mean, we have many more ICUs and transplant programs. We have cities with 7 transplant programs in it. I mean, insanity, right? When you think about world distribution of resources. So we have the ability to transplant more, but what that has created in this country is a ever-growing wait list, an almost demand to be transplanted situation. You see the debates going on right now about whether you can transplant a COVID unvaccinated patient, and yet not the same reciprocal on how do we get those donors to try and help that ever-growing wait list of patients who unfortunately die because we don't have enough of the organs. So those are some of my thoughts.
You know, if I just put in one, because I'm apparently Mr. Statistics today, the wait list has actually declined in the US over the last 5-6 years. We were once as high as 125,000-30,000 people, and we're now about 107. And this is paralleled the growth of deceased organ donation and transplants per year, which have tracked very closely the increase in donor registration rates around the country. It is pretty clear that the non-registered are a much more intractable group to get authorization from, whether it's the individual who didn't register or their family members. And if you look around the country by race and ethnicity and by region, you'll find while overall among brain dead donors, not DCD donors, which is not well tracked by comparison, but under brain dead donors, we average about a 74% donation rate of those who are brain dead and are medically suitable to donate. But that ranges from a high in the high 80s, low 90s among the white multi-generational English-speaking population, to numbers in the 50% range in the more recent immigrant and communities of color with varying history of donation, large population of as you know, of Texas and here in California, recent immigrants to the US who did not grow up with organ donation and transplantation, never had a pink dot or a heart on their license, and may have come from places with significant distrust of institutions that we have to deal with, and some who bring spiritual beliefs with them, maybe not religious beliefs, but spiritual beliefs that are not compatible with the idea of donation. So, and there we'll see rates in the 50% rate or sometimes below. Helping those individuals make that choice, that is the work of procurement coordinators and family care staff in each of the OPOs, working with families and individuals at the time of death. And frankly, of that group, the vast majority are not registered, and that is that personal work. But it has not begun to come close to the rate of the white multi-generational English-speaking community. And there is a tremendous, whether it's face-to-face conversations or whether it's donor registration for decisions in advance, as Brad was talking about, that make the task easier for everybody. That investment needs to be done one way or the other. My concern, and I think Brad hit on it very clearly, is if we have a history, which we do, of a registry that is legally binding, a register of donors, intentionally donors, not a yes or no decision on donation. It's I want to be a donor. If we make that a yes or no on donation, those legally binding no's will be a tragic lost opportunity to have a conversation with those families. And that's my one fear. I think in some cultures and countries, it can be perfectly effective, and especially when it's soft. If it becomes legally binding, it's a risk.
And a part of our success with our opt-in registry, I think, and maybe this is partly what's different as well from the UK, is we present that question very often for our citizens. Every time that they go to the DPS or a DMV for driver's license or vehicle registration, they're presented with the question. We now ask every year for individuals who pursue a hunting or fishing license. They're asked if they want to join the registry. And because of that, we're driving traffic to that registration opportunity. That was partly why I asked the question earlier of what's your mechanism for allowing people to opt out? Our concern too is that if we're going to put that same question next to do you want to be a donor instead of just join the registry, and it's a yes or no, people are going to have access to be able to answer that question. And I would guess that it would be more than 5% even in the UK. As you said, you're surprised how low that is. It's just maybe that people aren't finding their way to the registry to actually have that conversation. Interesting point that Tom raised as well. One of the things we also drilled down into in the 2019 survey is that while over 34% of Americans have indicated that they would actively opt out, when you drill that down by race, 44% of Black Americans would actively opt out. And they would be presented with that question frequently, again, as we have presented them with the question of being able to register. And so given the health disparity in organ donation and transplantation that already exists, are we exacerbating that problem even further by offering that question?
You know, a real world example of Spain, which we should compare ourselves to because of their high donation rate through time. I had a wonderful conversation with Martín Mañuelik, who ran the Transplant Procurement Management Program, still runs that, the OPO in Barcelona and so forth, and really a world leader in organ donation education. And asked him about and again with Beatriz Dominguez-Gil and Mata Sanz, who ran the ONT prior to her. How easy is it for someone to register their opt-out decision? And the answer is uniformly, it is not easy at all. There is no registry at the DMV. There's no registry when you get your hunting and fishing license. An individual has to do something like we have here in the US. You can put that on your advance directive for healthcare. That is a question that's built into these model advance directives in I think all, if not most of the states. That can be put on there. Most people never address that question. Most people don't complete an advance directive, so it doesn't become a material force in the process. But the countries that have opt-out have made it a point to not make this an easy thing, to put a legal barrier. And it sounds like the UK's approach is to not make it an easy legal barrier.
I agree that, oh, sorry, go ahead, Claire.
No, I was just going to say in the UK, like I said, it's as easy to opt in as it is to opt out. It's exactly the same. It's exactly the same process.
But you are still willing to hear the family's conversation on this if their loved one had opted out, you're still open to the family overturning that?
It's not really that the family would overturn it. It's if the family have more recent information that we don't have on the organ donor register. So that's not an overturning. That's actually, we discussed it.
Pardon me, updating that. Yeah.
So yeah, we still have that conversation. And in terms of, I think there was a point earlier on about how aware are people of the change in legislation, and is that partly why our opt-out rates are so low? And we did track very carefully what was the general public awareness of the change in legislation, and because we were responsible for the marketing in England, so we were very, very conscious of wanting to track that, and the awareness of the change in law and how to register a decision was as high as 80%. Yeah, I know that that's not 100%, which is right, but it was very, very high.
Yeah, I think that your term marketing is key, because especially in our country, it would be a marketing, right? You'd hire a PR firm, you'd have splashy Save Billy posters everywhere. We know that we can change laws on the dime based on emotional plea. It's happened multiple times in the transplant space, besides everything else. And so, our country is so legalese, we're so litigious, we're so anti-government right now. Both parties are that way, that it would absolutely be almost more of a marketing campaign, and with media and everything, than a scientific campaign, which is a little sad. When you think about that, we should be beyond that, but right now our country is not.
In England, the marketing campaign was still really quite neutral. So there was two-phased approach. So the first stage that ran for about 9 months before the law actually changed, came into effect, was the law is changing on this date. It's still your decision. This is what it means for you. So that was what was ran, not the pulling at the heartstrings or anything, but the law is changing. It's still your decision. It's time for you to make your decision. And then as we got into the final 2 or 3 months before the law change, which is actually when people actually start paying attention and do something about it, it changed very slightly to the law's going to change in 3 months. Register your decision, tell your loved ones what you want to happen. We didn't say save a life, or we didn't use that emotional pull, but at the same time we had the mirror that was very much using that emotional pull.
Well,
and
even the name of the law, right? I mean,
one of the interesting things that we see down in Austin when we address this each session is by even asking the question about should we switch to an opt-out system, and that our systems that have been proposed here are really truly opt-out systems. If they say no, we cannot visit with the family about that decision. One of the things, though, that's asking is, how do I go about saying no? And we have a system, we have a mechanism for that in our revised Uniform Anatomical Gift Act that all 50 states have adopted, and it's called a refusal. But it's a little more complicated. It's something that you have to do separate and apart from the registry system. And we provide people with information about that when they come to the driver license office and they have to answer the question. If they want to say, no, but I don't want to just not join the registry, I don't want to be a donor, how do I do that? We give them that information. I won't say that it's the easiest way, or that it is something that is easily accessible even at the time if the question comes up. but we just don't present them with that question. But asking the question alone is starting to ask the question in our legislature that is going to, I'm afraid, start to also disrupt some of the good that we have by asking the nuanced question about, do you want to join the registry, not if you want to be a donor. We have, Tom's right, this is also a large cultural question for us. We have the right to life groups that always are against this because they want to talk about the autonomy of decision-making for someone's own decisions. We have, as Tom mentioned, vaccine hesitancy and mask mandate hesitancy. We had our own Attorney General just today file a lawsuit against the CDC related to the mask mandate in airports and on airplanes, that it's not backed by science and therefore shouldn't be something that we should be required to do. So it's such a different culture and uphill climb, it feels like, just as it relates to our own individualism and our own autonomy and how our systems or our structures are built. So, just an interesting something there as well.
I would say I don't see the change in legislation as the magic wand that will solve everything. And you're exactly right. You have to take that. What's the culture? What's the general ethos? What's the feeling, not just amongst the public, but amongst the parliamentarians as well? So in England, we have, two main political parties. We have Labour and Conservative, both totally in support of organ donation. Nobody spoke against it as it progressed through Parliament. We had the media asking for it. We had the public asking for it. We had donor families asking for it. There was a really big, strong support for that. But we've seen in some other countries where it hasn't been quite that way, that it's not worked so successfully. And like I say, it's still early days in England.
Jury's still out.
But the jury's still out, if I'm honest. Yeah, but in other countries, we've seen, they've introduced Optout. They haven't really communicated it. It's gone against what the general culture is, and it's gone really quite badly. So you have to have, as Shelley said, you have to have that infrastructure. You have to have that cultural drive and that political will behind you. But if you've got all of those, in England, it's opened doors and provided opportunities that would have never been opened or been provided without that change in legislation.
We had that effort take place here in California back in 2010, when Steve Jobs, who had just received his liver transplant, spoke to Arnold Schwarzenegger and said, I think we need to do something to increase organ donation in the US, and we start here in California. And Arnold said, why don't we do like we do in my country, in Austria, where they have opt-out. And it was obviously compelling, and this moves a lot of people who have some experience with it. The idea, the concept that everybody is part of caring for their community and taking care of one another, it has a feel-good element, absolutely. I had the pleasure of talking to the Governor Schwarzenegger about this and sharing that US donation rates exceeded Austrian donation rates substantially, which spoke to the fact that it was a soft opt-out system and they didn't have legally binding registries, but not necessarily speaking to the nature of people caring for one another in their countries. Austria is a largely Catholic country, and Catholic countries tend to have higher authorization and donation rates than non-Catholic worldwide. So Austria does just fine, but it gets to the fact that it is cultural. In most countries, most decisions are how you move these forward. And, even politically, you have to start with what is the cultural homogeneity and what's the cultural support for this. One of the things that we know here in Southern California, where about 30% of our population is multi-generational English-speaking white population, and 70% is not. It is not a common culture. It's not a homogeneous culture, and it is very much an international culture. In fact, not a very large African-American culture here either. It's mostly international. So we bring a lot of different cultures and attitudes. The educational campaign, the cultural social change campaign, frankly, to move to a soft opt-out or to continue to do registration is really the same campaign. It's about helping people see the broader good that comes from this, and most importantly, the personal good. And at the end of the day, trusting the people and systems who do this work, that are doing the right thing for them and for their loved one. And that if we can earn that trust, we can see donation go up under either system.
I think that there are opportunities for us, given our opt-in system and the way that it's based in gift law, and that it's a legally binding decision for the individual who's made that decision for donation. I think there are some opportunities even within that to see improvement in who it is that's actually honoring that decision. To your point, Tom, 99% of the time, we do see that those individuals go on to becoming donors, but there are situations where, we're all familiar with when in a hospital setting in a grieving family and the individual's registered, the family's not wanting to honor that decision in their moment of grief, trying to actually sort through emotions and decide what's best. We need better accountability for all parties to make sure that they're honoring that first person authorization, regardless of the setting, whether that's, again, at the time of death, whether that is in a DCD protocol itself and following through and honoring first person authorization in the DCD context, working with our palliative care teams in our hospitals to introduce donation as part of the withdrawal of life-sustaining treatment process, limiting coroner and ME interference that say that donation is not possible for this individual because it's going to interfere with a criminal investigation when the National Association has found that not to be the case. To Dr. Hall's point, we're working on a campaign in Texas right now as well to increase our registry with a new campaign specifically targeted based on data to underrepresented populations and especially people of color that are underrepresented in our registry. So there's lots we can be doing within our own system to continue to still drive that number. I just become concerned when it becomes the opposite question, which is if you're going to become the donor and opt out actively. And then we're going to, again, because our system is looking to gift law, that is an indication of donative intent that does not exist and therefore becomes a problem. I'm curious how you've experienced rolling this out in multiple jurisdictions, Claire and Anthony, and what that impact has been. One of the things we also concern ourselves with is because we have this system that is based in 50 different states gift law, that an individual who is in a potential opt-out state that travels to another state, their non-action is going to mean something different in two different states. And how it is that actually is going to impact our system, I don't know what the legal ramifications are of that. I don't want to know. I think that the fact that we have a unified system already that honors those individual wishes, that aligns with our culture, that we should be looking for other things in our system to try to drive registration and to try to drive donation overall.
Do you think that the gift law is then more effective than opting out law?
I would say that, having that would be really the focus of the piece that Alex Glazier and I published in JAMA was absolutely gift law. The whole U.S. donation law, the Uniform Anatomical Gift Act, was put together by state attorneys originally who specialized in gift law, recognizing this was not that the only precedent for this was not medical law. It was the giving of a gift from one person to others, whether they knew them or not. And that law gives a primacy to that individual's choice. And because we have invested so much in helping driving people to that opportunity to say, yes, I want to register as a donor, even though the odds are like less than 1%, you'll actually be one. It is that notion of saying, making that generous offer out there, and you've essentially you've given that gift at the point that you check that box. The legal binding nature of that has been incredibly valuable. We certainly saw, while it's been legally binding in most of the country for years, not uniformly, but it now is, it still takes, when you start holding institutions, physicians, the clinicians, and families to that, it takes some very challenging, there are going to be very challenging cases and very challenging moments. It takes support of everybody involved. We got a nice dialogue in the chat box about New York State and the reticence of some hospitals to support an individual's decision. We all in the opioid world have dealt with those cases of reticence. They're far fewer and far between than in the last couple of years than they were 10 or 15 years ago. Today, the cutting edge of that is in the donation after cardiac death cases, where the brain death is much more black and white in this decision. And while there's still a living patient, the question of do you have legal right to rely upon that donation decision to register? Our council have said yes, and it stood up. But that is the current challenge, to help the caregivers in the institution recognize that we need to keep that opportunity to donate alive. But building on it as a matter of law is very helpful at some point to remind people this is really no different than an advance directive. And do you want to deny an individual's advance directive to be intubated or not be intubated, and so forth? Do you want to deny their last possible choice on earth? It's an interesting way to put it emotionally and remind somebody that no, that actually is a gift back to them, to allow them to make this gift. And I think that brings us back from the law to the human element of this, which at the end of the day, if we don't win people's hearts, we won't win their minds, laws or otherwise.
This is for Claire and Anthony. There's a question about how opt-in, opt-out has affected DCD. Like, how does that factor in the UK?
It hasn't really made any significant difference in terms of DCD versus DBD. Some of the data from Wales suggested it had a larger impact on DCD donation rather than DBD donation, but we still need to evaluate why that might be. I think my colleague Anthony may have his internet has failed him, I think, at the final moment, so I can't turn to him to ask for anything further, but it's not made huge significant impact that we can see so far, because Wales is quite a small part of the UK. The biggest population is in England, and it's just too soon to say yet what might happen. We're keeping an eye on it.
Great. Well, we have about 6 more minutes. Anybody have any additional questions? Please put them in the chat. I've been trying to get to all the questions that I can. And maybe in this time, Shelley, Brad, or Tom, or Claire, if you have any other thoughts that you feel like we haven't really discussed today, you can bring them up.
I think the important message out there is that no single legislative decision, opt-in, opt-out, opt-maybe, is going to fix our need. We have a huge donor need. We could expand our wait list with candidates tremendously, even further if we had the donors to supply. So every transplant program has to create restrictions just to not have everybody dying on a wait list. So I think we all agree we need more donors. We have more similarities than differences, and that structure and education of the population are key components for success of any legislative thing that you then add to it. I think that our country has a long way to go. And they want, but don't necessarily want to give. And we have to continue to work on that.
We do. And, Dr. Hall, you bring up a great point about the idea that this is only ever possible because of the selfless acts of the donors and the donor families that we work with. And even still, if all were to say yes, we're still not going to address what is the wait list. It's almost that the system or transplantation itself has been a victim of its own success, that we can't keep up because it's becoming a more viable option for more and more situations. And so, we do have to keep our donor families and our donors themselves making those decisions at heart, and know that we're driving them to the decision that we know that they support. Again, over 80% in the UK and over 90% in the United States support donation and would make that decision. I love the idea in the UK that you ask for an indication of religious preference or cultural preference in a different way as well, that gives further indication about what a person might want when someone's trying to make that decision for them because they've left that decision to someone else. But at the end of the day, we're not going to eliminate the wait list. The possibility, the opportunity for donation is small. Tom mentioned that earlier, but all in complete respect and deference to our selfless donors and their families.
If I may, I think a question came up in the advanced questions that's somewhat pertinent here. It asked about what is the how does this relate to living donation? And legally, it doesn't relate at all. Living donation, of course, is a decision, an informed consent decision on the part of a living donor to give to either an individual or to a stranger. But that is an informed consent decision. There's no presumed consent or opt-in or opt-out on that per se. It is a medical decision. But one of the other interesting questions came up is how is living donation around the world? And frankly, if we look at to try to really close the gap, the biggest need for transplant, of course, is kidneys. And the one organ that is the easiest to give as a living donor is kidneys. And it is varying degrees of commitment to doing this around the world. As a general rule, this is the same data source, the era.data from 2019. And the general rule, if you look at this list, is you'll find that countries with substantial, higher deceased donation rate organizations and programs and better success in deceased donation tend to not be as high in living donation, but countries that are dependent upon living donation to transplant kidneys and livers into their patients tend to be higher. So Turkey is an example. Israel's been up and down. They've done a good job on both in recent years. But Saudi Arabia, as an example, the US comes in at, I think, number 6 or 7. Japan, which has struggled for years to have a viable deceased donor program and has really put a lot of effort, but has not made a lot of headway, fairly high in the living donation realm. At the end of the day, if we're going to put our efforts into trying to increase the number of kidney transplants here or anywhere in the world, the greatest opportunity is in living donation. The number of potential donors is not in the tens of thousands, it's in the millions over time. And of course, it is a big ask. It's a big ask from somebody, especially to give to a stranger. But there's a lot of people who would be giving to someone they know and love. And our own view is putting as much effort into trying to increase living donation as increasing donor registration. They need to be parallel paths, not just one or the other.
I would agree very strongly with that. As like I said earlier on, there's no magic wand, and there's no, you have to have everything working at its absolute maximum potential if you're going to save as many lives as you possibly can. So, it's not an either or. You need living donation, you need deceased donation, you need to be pushing the boundaries, you need to be looking at innovation and what else might we be able to do, with the machine perfusion coming along and all those. You need the complete package if you're going to maximize the potential for the numbers of lives that can be saved through the gift of donation one way or another. And my final comment would be, there's a few words that have come up time and time again. So that concept of the gift, is absolutely paramount and should never be, taken away. And it's what we always describe it as. It's the gift of donation, whether that's deceased or living donation, and that sense of autonomy as well. It's your decision. It's not the state making that decision for you, it's your decision, and this is how you make your decision. And I think that is an absolute, those two concepts of autonomy and the gift are really, really important, regardless of whichever legislation system you have.
All right, this has been an incredible discussion. So thank you very much it really has been so fantastic. And I'm going to pass it over to Deanna for closing remarks.
Probably be helpful if I could find my mute button. But I just want to say, wow, that was a truly fantastic, I think, polarizing discussion. So it'll be interesting to see how things unfold in the future with respect to an opt-out donation system and all the subsequent implications here in the US. I think you've certainly all given us a lot to digest and evaluate. So I want to thank you all for your time today. And for anyone that's with us still, anyone interested in reviewing some of the data that was shared by Tom and Brad, please feel free to reference the handout that will be shared and posted to our website. Additionally, the NHS team has shared that their data has been posted to their website, and they're happy to share that as well. So we'll include that in the handout for your reference as well. So with that, I just want to extend again a sincere thanks to all of you, the entire panel, everyone in attendance, for your time and participation today. As always, I hope everyone found the discussion to be valuable, and I hope to see you again in the future. So take care, everyone.
Thank you all.
Bye.
Bye.